Morning, everyone. Good morning, everyone. Thank you. Welcome to London. It's great to have people back and in person and see everyone catching up. Hopefully you'll be able to enjoy the nice sunny weather when you get a chance. We've got a number of days of some very interesting discussions. So hopefully people will get engaged and start to have some fun with that. I want to thank the conference team and others within the organization for hosting the event and doing such a good job. I want to remind you that there is a reception tonight where we can get together and share a drink and get to catch up and really just enjoy yourselves. I know your time is valuable, so enjoy yourselves, and we'd love to get your feedback as discussions go on through the next couple of days. So without further ado, I'll turn it over to Kelly Carew, who will introduce our plenary speaker.
Thanks, John. Good morning, everyone. It's lovely to see everyone. My name is Kelly Carew, and I'm the Chief Communications Officer at SNOMED International. Welcome. It's lovely to see all of you here so early today. I think we're very fortunate that such a large amount of the SNOMED International community of practice has been able to convene here in person today. Just judging yesterday from the meetings that started and the conversations that have been had, I think they've been exceptionally fruitful and productive, so thank you very much. I will note that we also have many attending us online today, and I'd like to thank them for taking the time to log in and tune in to the keynote presentation we have today, as well as the following community updates, especially when participating is undoubtedly filled with more challenge when you are engaging virtually, so thanks very much. On to the introduction of today's keynote plenary speaker, which is Dr. Andrew Roddam. Andy is an internationally renowned epidemiologist with more than 20 years of experience. Sorry, Andy. Having earned a doctorate in statistics from the University of Oxford, a postdoctorate in infectious disease epidemiology, Andy has had a range of academic and industry-focused positions over his career thus far, with primary focus being on the application of epidemiology to further the understanding and advancement of human disease. Since April 2020, Andy has been the CEO of Our Future Health, an organization that is leading the UK's largest ever health research program. And in the same year, in October, Andy joined us as a SNOMED International board member, and as a dynamic part of that ecosystem we have going. He has provided his strategic insights, perspectives, opportunities on enriching the development, use, and innovation of SNOMED CT. So a couple of points of guidance to our audience before I hand things over to Andy. We will have time following Andy's address to have some question and answer. So for those attending online, I encourage you to use the chat function. We'll facilitate those questions following Andy's address. For anyone in the room, please just raise your hand, and we have a wireless mic that will ensure it gets over to you so you can put your questions to Andy. Lastly, the session is being recorded this morning, so you'll be able to reference it following the business meetings. And with that, I invite you to join me in welcoming Dr. Andrew Roddam.
Thank you. Right, so what I'm going to try and do in the next 30 or so minutes is tell you about our future health. And to do that, probably in three parts. One, to motivate why we need to change healthcare globally because of the problems that exist currently in the healthcare system. Secondly, how you do something which we're trying to do at an immense amount of scale and speed of what we're trying to deliver against. And then finally, talk about some of the work that we've been doing with SNOMED, with Rory, with Kelly, Ian, and others in the team on what's the opportunity when you're doing very, very large biobanking style activities which are trying to change healthcare. how you can actually sort of embed data, the architectures, the data architecture that we need to deliver things in the future, which will be future-proof for the use of data in healthcare decision making. And this is, as I go through, I've been told that I'm either bonkers or insane for trying to do what we're trying to do in this program. Our Future Health is a really intense amount of activity, and to say that you start this, as Kelly sort of alluded to, in April 2020, most of you will remember what happened in March 2020. I started a job where my sole purpose was to get people out of the house, stick a needle in their arm and take blood from them, which was not trivial, whilst COVID was a little thing forcing everyone to stay in their house. But to go back to why is this important? And I sort of go to, for each and every one of you in this room, you can all think of a family member, a friend, a relative, a child who's had some chronic disease. And if you think about that person who's had that chronic disease, you can start to think about what impact did it have on their life? What did it do to them? People who have strokes, who have heart attacks, who get cancer, who have dementia, and think about the impact that it has once they've had that diagnosis. And in terms of the healthcare system, what happens is that you see exactly what has been seen pretty much in the UK and around the world today, that you end up with many, many people needing quite a lot of healthcare in the latter part of life, and actually living in very poor healthcare quality in that end part of life. You know, if I look at my own relatives, my mum having dementia for the last year of her life, the sort of burden both on the family, on the individual, and then on the system is quite intense. And if you look at the UK today, we've got somewhere between 7 and 10 million people currently sat on waiting lists, waiting for consultant-led care in the hospital system. We have targets of trying to get to 85% of people within 16 weeks for cancer treatment. It's currently, at best, hovering around 50% and possibly dropping even further. So the impact of these changes in the healthcare system, the impact of the fact that we keep people alive for longer but not necessarily in good quality of life and later life, is a real challenge. And if you start to think about what that impact looks like in real terms, so in the UK we expect, currently 2.5 million people living with cancer. It can get as high as 4 million people in about 5 to 10 years' time. The cost of diabetes treatment and the size of diabetes treatment is growing exponentially when you look at the earlier age of onset of diagnosis of type 2 diabetes, partially fueled by obesity. The amount of hospital admissions for cardiovascular disease costs the UK Health Service somewhere close to £19 billion every single year. And the dementia costs are easily doubling, if not tripling, over the next sort of 5 to 10 years. Based on where I grew up versus where I live now, there's a 10-year difference in life expectancy on average for a person. If you were born in the UK today in an area with the lowest level of deprivation, you have a life expectancy which is 19 years less than if you're born in the UK in a high level of social worth. That life expectancy in the lowest deprivation level in the UK puts you on par with areas of the world where we would have classically said had low life expectancy. So areas of the Indian subcontinent and Bangladesh, areas in South America and areas in Africa. And that's in what is arguably a developed healthcare system with very, very good treatment and very open access, given that we have a single payer system here in the UK. So there is a real need to think about how we start to solve the problem of getting to people too late, not preventing and not intercepting with them earlier. And that's really what Our Future Health was about. This was the sort of motivation for it probably 5, 6, 7 years ago. It is, how do you find people earlier in the disease course, intervene earlier with treatments that might work? And those treatments may be behavioral treatments. They're not necessarily, I'm not always thinking of drugs or vaccines. I'm thinking of interventions which will make a difference to a person's life. And that you might ultimately do one of a few things. You might find them before they get the serious part of the condition, so earlier stages in cancer. You might find them at a high risk and target the intervention to them in the right possible way. So instead of using blunt agents like age as we do for screening for most cancers and most cardiovascular disease, you may find the high risk versus the low risk. And you might actually prevent and cure people from having the condition in the first place. And that's the sort of thesis essentially around what we're trying to do with our future health. And I want to put the context of what lots of people do. This was an editorial based in JAMA back in 2014, and not a lot has changed in the world since then. I think the only thing that's probably changed is you can delete ICD-9 and put ICD-10 in the picture. But the sort of reality is that sort of top T is where most people think healthcare data is sort of sitting. The reality is that top T is healthcare data for people who are seeking healthcare. These are people who are principally sick. They're being seen by the service, they're getting a diagnosis, they're having tests done, they're having interventions. And that's the bit that we study the most. The rest of it is the context of the world that I'm trying to live in, delivering our future health, which is there's a whole bunch of other bits of data which are really, really interesting about you all as individuals, which aren't your interactions with the healthcare provider. It is understanding your genetics. It is understanding your lifestyle. It's understanding when you go to the gym. It's understanding what you report on social media. It's understanding the environment in which you live. All of those things will give much greater insight about you as individuals and allow the tailoring of treatment and interventions and preventions to you in a much, much more appropriate way. And the reality is, it is really, really hard to sort of operate in this space. Trying to find all of those data sets, trying to find all of those data sources and trying to join them together in a sensible way is really what we're looking to do. At the core is clearly healthcare data. The next level down for us is then genetic information about you, because genetics is probably a most powerful predictor. Arguably, and there are many arguments, and I end up going to many meetings talking about this, but the sort of context determinants of your behavioral characteristics are almost best described by your sort of shopping data. And that's why Amazon, in the UK, Tesco's, Waitrose, Sainsbury's, get the greatest insight about an individual from what you purchase on a regular basis. Amazon set themselves up very much as a data company to sell data on that particular concept based on what books you buy. And that's a really, really important thing, because what I really want to be able to do is to find the individuals who are hyper compliant with when you tell them and just give them the thing they need to do, and find the individuals who are hyper non-compliant and put in support and activity programs which will encourage and enhance their ability to do against the things we're asking them to deliver against. And just to talk a little bit about genetics and why genetics is important here, most people, when you say genetics, immediately jump to the thing on the left-hand side of this picture, which is pedigree inherited genomics. So things which you carry, which you will pass on to your children because you happen to have a particular carrier status of a monogenic disorder, cystic fibrosis, sickle cell anemia, the sort of classic genetic conditions. The next step from that being the things like BRCA1 and BRCA2, which are, if you're a woman, incredibly challenging to be carrying those particular genes. However, they're not single variants. There are many, many variants on the gene. But carrying a BRCA1 or BRCA2 genetic mutation gives you something like an 85% lifetime risk of developing a breast or an ovarian cancer. So a really important finding for people who are carriers. But that's the easy bit of genetics. The harder bit of genetics is when you say, well, what about people having a heart attack? There are many, many little tiny bits of genetic variation that we carry, which if you add them all together in a sensible way and create a score, will tell you something about the risk of heart attacks. There's also many, if you look at breast cancer, which is the picture on the right, there are many variants that you can add together to look at the risk of breast cancer, not necessarily BRCA1 and 2 risk, other variants that you might be carrying in your gene makeup. And what you can see is that if you create this score, you get a very, very wide distribution between the highest risk and the lowest risk. And actually, this is non-BRCA1, BRCA2 carriers. These are general members of the population who have no genetic predisposition, no family history for breast cancer. And at the highest compared to the lowest, it is equivalent to carrying a BRCA2 mutation. And that's a really important finding, that if you think about implementing screening services for breast cancer, knowing the really high-risk people may need to be screened more frequently than the really low-risk people could transform the distribution of resources that you use in a healthcare system system to deliver that sort of intervention. And that's what we're trying to look at in this large sort of program. The caution on all of this is we've only ever really screened and sequenced and genetically managed white European ancestry individuals. So currently, the bulk of the genetic evidence that we have around the world has something like 87% of it comes from white heritage. And that is not reflective of the global population. And if you look at the epidemiology of common cancers, we know that if you go through India towards the China sort of world, the distribution of cases of esophageal, of stomach, of lower gastric tumors are very, very different. And if you look at the Japanese migrants and inhabitants into Hawaii and then into the west coast of the US, moving people from one country to another causes a change in cancer incidence. So it is very difficult just to focus on the genetics currently, where it's based purely on Europeans. And if you do that and then apply it to every population, you run a real risk of increasing disparities in healthcare by assuming that white European heritage applies to all of the other ancestries that we have around the world. So that's the background. And then what is the madness that we're trying to do to try to solve this? So Our Future Health came about as part of a government program for investment. It's going to be, hopefully, the UK, arguably the world's largest ever health research program. It's designed to look at testing and discovery and approaches to effective intervention, detection and treatment of diseases. We're trying to collect and link all of these different sources of health and health relevant information, including genetics. And then the little bit of a giveaway is we're trying to do this on 5 million people in the UK, reflective of the UK population. That means that that's about 10% of the UK population, of the adult UK population, that we need to try and find and persuade to take part in this program. And they have to be reflective of what is the UK's sort of demographics, the socio-demographics and the ethnic groups demographics in the UK. It's an open access, ultimately open access resource. It'll let people, what I'm building is just the platform for people to use. We're not going to do the research. There's enough just to build the platform. But it's to empower researchers to come along and ask all of the sorts of questions like, how might you treat this group of people? What if you've got a new biomarker test you want to deploy? What if you've got an intervention which helps people lose weight better than what you think other people do? And what we're trying to do is, how do you recruit 5 million people? That's an interesting question. We're some way along the road to doing that, but you have to do it in a very different way to how you think of doing health research normally. If you're going to get to 5 million people, you have to think about consumer research, and you have to think about treating people as customers, and think about making it really simple and sensible and easy for them to join. Getting to 5 million people in the UK, to put it into context, makes us one of the single biggest commercial brands in the UK. We will be bigger than Xbox. Xbox do not have 5 million people. We'll be bigger than the single largest online shopping service in the UK, Ocado. We'll be bigger than the majority of the household names that we know and love. You know, all of the dating apps do not have 5 million customers, as I've been told, although I'm still trying to do the research to work that bit out. But taking that sort of consumer approach, what we're trying to do is say, how do we make it really simple to get from entry to do the appropriateness of doing consent and getting people to agree to what we're trying to do, and to collect blood from them, and to do that in a way that engages and keeps people throughout time. We do take consent to link to their records in the UK and the NHS. We take consent to recontact them in the future. And rather uniquely compared to most large population studies, the intention here is, once you're in Our Future Health, we will go back to you many, many, many times and offer you the opportunity to take part in lots of future studies. So a sort of consent to recontact approach. And ultimately, uniquely, we're offering people the opportunity to get health-related feedback so that I can give them information back based on their genetics that they could be buying from 23andMe, Ancestry.com, and many other commercial providers, and we're giving it to them for free, which is quite a nice hook if you're trying to get lots of people to join you. What we do is we take the data, we take the samples, we do an extraction, put plasma in lots of tubes. I have a freezer which is capable of storing 53 million plastic vials of plasma in a nice robotic system so that you can go and them off and you put them in the front door and the robot goes and sticks them in an ice freezer. We extract DNA every day on the samples that we take, and we can ultimately add in lots of other data types over time by building APIs to various connectors so that we can get personal health information, we can get Apple Watches, Garmin's, Fitbits, anything you want, you can bring back in as long as you get a personal authorization on the API to get that connectivity to happen. It is a partnership, and I think this is the most important thing, that you cannot do this just as an individual organization or as a government or as a company or as a charity. A lot of the work over the first couple of years was building this partnership together. We're funded initially through and just short of an £80 million grant from the UK government. I've also raised another 160 million from the life science industries, so 16 of the leading pharmaceutical and diagnostics companies have invested. We're still continuing to talk to those companies to invest. You can see who they are in the bottom left. We have 14, I think, I can't remember what the number we're up to, but most of the major medical research charities in the UK are partners with us, so that we can use their brand, we can use their network and their supporters to encourage people to join. And I'll wander through quickly the sorts of mass amounts of community activity you need to do to raise awareness of something on the scale that we're trying to do. But it's also a network with the NHS, with government, with the academic and with the clinical community in the UK to enable this to be really delivered at the scale that we're wanting to deliver it at. So as I said, we made it relatively simple. One of the wonderful advantages of the UK is there is a central register of every single person who is registered with a GP, and I can essentially breach that confidentiality and write to everybody in the UK to be able to invite them to take part. That's a really, really powerful thing which does not exist in many countries, because I can use an actual personalised name and address, and it can come centrally from the NHS. Side challenge is there's 70-something million people on that register, and there's only 50 million people in the UK. NHS England is still trying to resolve that particular conundrum. That letter essentially gives you a QR code and a scan. You go to a website, we built a registration, you go through a consent, there's some help videos, you end up filling in a questionnaire, and then you book an appointment to go along and give blood. And what we've tried to do with that is to make it as simple and as easy as possible. We essentially followed the UK COVID vaccine rollout model, so that we have 3 tiers of kind of attempts to get people to give blood. We've hired shops and shopping centres. Amazingly, COVID has helped quite substantially by leaving lots of vacant retail space. So in major shopping centres in the UK, we've hired a shop for 6 months, and we've set up a 14-person high throughput facility that'll see people and do a 20-minute appointment, get their blood, get them in and out, get some measurements from them and through. We have a partnership with Boots as a community pharmacy, and this is really interesting in the UK. Community pharmacies are very regularly giving healthcare. This was the first time Boots had ever taken venous blood. And taking venous blood is very, very different from sticking a needle in an arm and giving a vaccine. And this is possibly a way that healthcare starts to change in the future, where you can start to embed much more at the community pharmacy level and much less at the sort of hospital GP practice level. I have a suite of 5 40-foot trucks, which for my sins, I end up in car parks in supermarkets around the country, standing in front of them and talking to news reporters regularly on a Friday morning as we move these vans around, but we put them somewhere for 4 weeks, we move them to the next location, so we bring it to the community to be close to the people in an area where they are normally going to get them to take part. And only last month we did our first piece of work in universities. We set a pop-up clinic in Leeds University to try to do something which is really hard, which is recruit young people. Anyone under the age of 30 thinks they're invincible, and therefore when asked to do something about health research, shows no interest in it whatsoever. Men are not so dissimilar from that generally. Women always take part, men never ever take part. We started in October 2022. We see roughly 1,500 to 1,700 people every single day of the week, and we put them through this process. So we're doing somewhere around 1,500 to 2,000 health checks a day. In the 6 months from October to April, and this data is whenever I said it was, 30th of March when I last looked at the dashboard, we've consented about 359,000 people at the top end of the digital funnel, And that goes down through 139,000 attended appointments. So we've got 139,000 samples already in the bank, and 115,000 people who've got the sample, the extract, the quality of the sample, they filled a questionnaire, they've done all of the consent bits, so they are complete and total participants. And obviously, a lot of this we step through over time and we'll boost the numbers up. So, take the 359,000, actually over 65,000 of those people just joined the program because they saw us on the news. They didn't join because we sent them a letter. They've simply joined because they've seen some public awareness of it. So there's a lot where we need to go to areas to be able to recruit those people. We have a lot of media attention in the UK. Thankfully, he has to say, all positive so far. I think one of the biggest risks of the program is always that there's going to be some negative media at some point in time. And, that's kind of one of the preparatory things that we do, but we've appeared on ITV News, on radio. I've done interviews, Rahib, my CMO's done various interviews. We're in sort of weekend supplements. We have sort of healthcare sort of things that pop out all the time. We did one media release on a Friday afternoon. Within a week, we had 300 news stories or mentions on the basis of that particular release. And we get a lot of positive news stories coming out of government. Something I never knew how to do, but I now am an expert in. We do a lot of targeted digital marketing. Between October and the end of January, we displayed 33.9 million digital adverts across YouTube and Instagram and Facebook. We geo-targeted them to areas that we were operating them in, and we personally target them to groups of people, of populations who were not responding to our campaigns. We got a really high pull-through rate. We got about 3.7 million engagements. From that, 10% engagements from a digital display advert is really, really high. And we've got multiple video views, people who pull through from those engagements to our website and to the YouTube channel and pick down all those videos that actually make this a reality. We appear on digital billboards, at buses. Occasionally I go to a city and don't really realize just how much advertising we're doing, and you walk around, there's a bus pulls past you with the thing on the side. We're on trams, we're on marketing, and in various bits of London, there are sort of banners hanging from telegraph poles or street lamp poles, where we're using it to increase the awareness of the program. In terms of when you join the program, one of the things we really ask participants to do is share onwards their taking part in the program. So we give them real collateral to enable them to do that. So there are selfie abilities within each of the recruitment sites that are built in. There's a social sharing card that you can take a selfie of yourself with. There's a leaflet if you just happen to pop in. There's lots of people wander past the car park and go, why is this truck sitting here, asking to take part. And there's a sort of thank you card for saying thank you for taking part, something which is really important to recognize the effort that people have gone to be able to take part in this research. We get lots of positive stories across government, academia, NHS, industry, community groups, the majority without us prompting, which is actually really nice. About 6-12 months ago, I would go to things and I would have to prompt people to actually say things. We now get secretaries of state, even the Prime Minister and others who will actively promote this as a study that's happening in the UK and people should be taking part. And that's really powerful for us in trying to recruit and garner the support that we need to deliver this. And one of the most nicest stories we got is the one down in the bottom right, where we actually just invited by routine letter the medical director of the Bolton NHS Trust, who accepted the letter, came along and took part. He then ran a story, his employer ran a story, and that sort of self-sharing across the medical profession is really, really helpful to kind of build the trust and garner the support that you actually need. We have lots of volunteers who tell us their stories. You see the videos that we do and the stories that we do coming out on our media channels. Many, many people who have a personal connectivity to wanting to help either themselves, their relatives, or the lives of their children in the future. And they happily tell those stories online to us and through the videos and materials that we record about them. So how does this ultimately help? Well, what we're trying to do is build this picture of their health, or build this picture of what's happening to them using health-related data. We have this questionnaire. If you know UK Biobank, it's very similar to the UK Biobank questionnaire. We've updated it by 20 years, so we ask a bit less on smoking, a bit more on vaping. But things like that, where the exposure index has changed over time. We have a blood sample. We have the ability to go back to them We have genetic data on them, and I'll come on to a little bit about what that genetic data is. And we have linkages, hopefully quite soon, to the hospital, to the death, and to the cancer registries. In the future in the UK, I hope, although I say this many times and I have done for 20-something years now, we'll have access to primary care data in the UK from GPs. It is an incredibly hard thing which our dear friends in the NHS have failed to be able to deliver for us for the best part of 20 years for a whole host of reasons. Will they be able to get to this personal data, to administrative data, and just continue to build out that data set in the future? So the sort of left-hand side is what we're focusing on now. We're going to empower researchers from day one, essentially. So we already have a research environment platformed out and available in closed beta. We'll go to a fully live environment in the summer with all of the data we've collected. We'll do sequential quarterly releases of data as we go on from that. We're working through what it takes to release the samples. We only have a little bit of blood on people or a little bit of plasma. How do we manage that and make sure that precious depletable resource isn't depleted too quickly? And that's really important. And then finally, we'll get through to the how do you recontact people? It sounds the most trivial problem. It actually is really, really complicated because of privacy and protection, that if I start recontacting lots of people, how do I maintain the privacy and the identities of those individuals from who's being recontacted and allow re-identification within the database of really, really complex information? You probably wouldn't be surprised to know that people in the security services in the UK are very, very nervous about having a database which has 5 million people, their genetic code, their name, their address, their mobile phone number, and their email address in a large platform. So we have a lot of interest from the security people about how we maintain the security and privacy of that particular store of information. I always like this picture. It underlies this, it shows the simplicity of something which my CTO will tell me is the most complex platform he's ever had to build. Essentially, we have sort of 3 layers to our sort of participant and data platform. We have a participant front end, which is the sort of registration, the consent, the questionnaire, the sort of blood sample booking system. There's a minor little integration with a few LIMS systems on the side for all of the sample handling that goes on down when the blood ends up being couriered from sites every night to a central laboratory in Milton Keynes and then coming back and stored there. There's a little bit of data which sits in the data platforms in the middle, both unidentifiable and pseudonymized data. There's a set of linkages we have to do to the NHS, which has data flowing in lots of different guises, formats, and shapes. And then there's a set of research platforms at the bottom, which have the sort of research environment, which essentially is DNA Nexus's environment hosted on top of Azure, which is similar to how a number of the other large cohort studies around the world have delivered this, which also has to then let in researchers around the world. And we've also working through with the people in the UK on how do we accredit other research environments around the world so that you don't assume everyone comes to you to do all of the analysis, but there are places where it could go, often for reasons of compute power, that we won't have enough compute power just on the research environment that we procure, but it may need to go elsewhere. And what are we doing with genetics? Well, with genetics, we're going to do a new type of array that's just been designed by Illumina. It should, in the next few weeks, be finalized. We finalized the design content of it a few weeks ago. It'll have about 950,000 variants on that particular array. And from that, we'll calculate these sort of risk scores for about 53 different common diseases and traits. So that's information aggregating together from those 950,000 variants, a whole bunch of things. We'll also have pharmacogenomic information on that array, so understanding common pharmacogenomic variants associated with diseases. And the last thing that'll be on that array, which is quite unique to us, is we're working with the Blood and Transplant Service in the UK for blood transfusions, and we'll recruit blood donors. And there's a real interest in going beyond traditional type and cross-match to go to genetic cross-match to prevent infusion reactions in people who regularly receive blood donations. And what we're doing is doing the genotyping on that blood group so that you can do a genotype-specific cross-match, which will be really important when you get down into HLA sort of variants. That'll all appear on the platform. will give people this opportunity to get these personalized assessments. That involves quite a lot of work with the NHS, so that I don't suddenly overwhelm the NHS with a whole bunch of people who I say are high risk of something, and they all go running off and asking for help. It's not something we're trying to do, but ultimately it'll mean that you can start to recruit people on the basis of risk profile into future studies. So you can find high risk and low risk individuals and invite them to take part in research in a very stratified way, which will be something truly unique around the world. How are we interacting with the NHS? I thought it was just important to kind of call a couple of these bits out because it is really challenging. And I think this is one of the areas that certainly when Shelley, Rory and I first talked about sort of how could SNOMED work with us is we need to pass information back to the NHS, and it's not obvious for some of the things that we want to pass back how you actually do that. The easy bit is at the moment I do blood pressure, cholesterol, lipid profile on everybody at baseline. I find quite a lot of sick people in the UK. To give you a snapshot, currently every day about 1 in 4 people who turn up at our clinics are hypertensive. Some of them are clinically hypertensive and we have to ship them off to A&E pretty much immediately. And I think the highest reported pressure we've had so far is somewhere around 200 or 210 over 150 of people who are just walking in on the street. About 1 in 2 people who turn up into our clinics also are hypercholestemic, often between 5 and 10. So again, there are many stories that get shared back to us of, by the way, did you realize you've saved my life because I never knew I had high blood pressure, or I never knew I had high cholesterol, or I had critically high blood pressure. And, you know, had the panicked look of an A&E doctor when they take the blood pressure again, going, oh my God, what are we going to do with you? So there are real sort of tangible benefits, but we need to pass that information back into the clinical record because it forms part of clinical care in the future. If we want to offer feedback, there's a real tension between, is this a clinical grade level of information about risk or not? And there's a real tension about, if you put these sort of feedback things, how do you put them back into the medical record? These things change over time, the variants change, the calling of the genotyping changes based on the calls that we use for the imputation algorithms, the variants change a little bit because people come up with a better score. And there's a real question there about what do we need to do with that? And I think ultimately we know the NHS want us to work with them closely on how we put this record together, whether that's through the NHS app, whether it is direct messaging back to the primary care record, whether it's messaging to NHS blood and transplant about what variants are, or even the thing I think is the lowest hanging fruit but the hardest thing to do. If you know the pharmacogenomic variants, how do you embed pharmacogenomics within prescribing in primary care records so that you don't make mistakes based on pharmacogenetic information in the future? And that's a real challenge, but I think a real opportunity to think about how we start to solve this. And finally, I would just say, you know, the work that we've done looking at how do we use SNOMED and what are the opportunities for kind of working together. You know, currently, it's a great place to be. We're at a greenfield site. We're architecting a data store however we want to architect it. But that means that we have to take quite a lot of decisions about how we put that architecture in, because moving and changing things in the future is non-trivial. As everybody probably in this room knows, you never ever want to change a data architecture. My research community, whether you go to academics and clinicians, everybody has a preference for a data model. Every time I talk to somebody, they tell me, oh, it would be great if you could just put this model in. It's like, well, yeah, it would be, but thanks. The healthcare data that comes to us comes in many different types of aggregated coding systems. So if you just take NHS primary versus secondary care, if I get secondary care data from the NHS, it comes in ICD-10 and OPCS4 codes. I don't get the SNOMED codes from the secondary care. When we get to primary care, it will start to come in SNOMED, READ, OXMIS, depending on the history of the system or how far back we can go. And that'll make a very different sort of paradigm for the sort of architecting we need to do. But there are quite a lot of challenges. If you go back to that picture I showed at the start with the sort of breadth of data that we need to store, how we pick the right architecture for multiple data elements, some of which is representable in SNOMED and some of which isn't, is a real question and challenge that we're still sort of working through that sort of ideas about. Things like genomic data and you're doing variants versus sequences, how you represent that data in the best possible way is a real question that we haven't really tackled yet. And ultimately, at what point do we start to adopt this in the architecture? Where in the layering of all of the elements that we might need to bring together do we bring this into the sort of solution point? And with that, that's pretty much what we're trying to do with our Future Health. It is one of the most intense projects I've probably ever been involved in. I used to work in the pharmaceutical industry for the best part of 12, 13 years. It makes working in the pharma industry look like a really nice job that I sometimes go back and think I only had to work 10 hours a day rather than 25. But if you go back to why are we doing this, I think going back to that, trying to get to people, stopping them being unwell in the first place, helping that individual that you all know live a healthier life for longer, bringing all of this information together is exactly why we do that every single day, because that is what will make a difference. And if we don't do this now, the sort of healthcare systems around the world are already falling over in trying to manage the burden of growing numbers of people being diseased and being treated. And whether you're in the US or the UK or Europe, there are many, many challenges in how you manage healthcare at the moment. And this is one of the many answers that we need to really pursue to be able to think about a different life for everyone in the future. And with that, thank you very much.
Oh, wonderful. I'll take that back. Thanks, Andy. That's super fascinating. I think what strikes me is the approach and how you've done something, including partnerships, really bringing in the networks of the individuals that you have reached to continue to amplify that and get more in. It really is, a rolling stone down a hill once you start it going. And I think that's been really impressive about the approach. Thanks for sharing that with us today. I would like to open it up for any questions, comments, observations. Okay. And Allison kindly has a wireless mic here. So maybe let's start over here.
Hi, everyone. First of all, thank you for the presentation. It was very inspiring. So my name is Aaron, the CEO of the International Social Prescribing Pharmacy Association. And basically what you described to me was, for me, the perfect blueprint for precision social prescribing. So my question to you is there any plan at some point to include the generative AI, like maybe not GPT-4, but like more ethical version of to enable data-rich extrapolation of result, which is ultra personalized to the patient genetic profile and the social condition?
Yeah, so I think there's probably, before you get to really complicated AI, I think there are some very simple things you can start to do, and we want to be able to start to look at those. And I think that's the power of what we're trying to offer, which is, are there patterns that you can examine about an individual, which could be simple patterns that you can observe with traditional models. They could be really complex patterns that you need to go to an AI ML sort of model to really unpick about the individual, which then says that if you're stratified by that sort of pattern structure, will you see better outcomes across those groups? And the sort of trivial example I gave is, what about screening services? Screening, we take really blood tools, we use age, and we say everyone between 50 and 70 gets a breast screening appointment. Now that may sound really blunt, but actually there's a really practical implementation question there. It works because it is really, really easy to find people between ages 50 and 70. If you said, I need to go to find people between ages 30 and 70, but between 30 and 40, all I want to do is take high-risk people who've already had a genetic test done and their genetic profile, that becomes a really complex implementation question. So I think the opportunity is there to think really hard about doing sort of what you might consider and call deep consumer phenotyping or deep consumer experience. But I think tailoring and looking at the responses in the tailored areas is clearly the way that we've got to go, because otherwise you're wasting resources and trying to treat everyone in a one-size-fits-all approach.
Thanks, Aaron.
Thank you very much for the great presentation, Andrew. It was really enlightening. I'm a pathologist, and I've got two questions for one. In Britain, you have to go for 2 for 1. One of them is essentially the best data you have is the one which is already in the bank. How you are planning, or are you planning to integrate all of the data of your would-be or present participants from NHS system? That's question number 1. Yeah. And number 2 is, I really like your vision about sort of collating and collecting the data. Are you planning to store the raw data and make it available for the other scientists who may want to use it in different ways? Thank you.
Yep. So in terms of the data that already exists, we have applications currently in with NHS England, and again, the other complexity of the UK is there isn't just one NHS, there are 4. So I have applications in with NHS England, NHS Scotland, NHS Wales, and NHS Northern Ireland, because they all manage their data themselves, to access primary care, secondary care, which is hospital episodes, so the essentially the administrative returns from the hospitals, death registers, cancer registers, and the diabetes register. So they assimilate the information nationally, they can pass that to us, and we can store it in the platform so that other research can come along. And then your other question about the sort of raw data, yes, well, the raw data is stored at the sort of level in the bottom of the data platform, if you like, in the sort of foundational layer. Depending on what bit of raw data it is, we don't have any reason not to promote it to being available to researchers to come along. So the genetic information, for example, will take the raw information from the SNP array that comes out of the machine. That'll be available for researchers. We'll also make a cold, imputed, and cleaned up version available as well for people who just want to be able to access that.
Thank you. Hi, I'm Samuel. I work for a health tech startup, and I wonder, how do you plan to, I mean, you talked about you have different layers of data, right?
Yep.
You have the raw data at the base level. How do you plan to manage access to those different layers if, say, private sector players or researchers would be interested in that data more broadly?
So essentially, there's a data access policy overseen by an access committee, and that policy applies to everybody, independent of whether you're in the NHS, whether you're clinical, whether you're one of the 16 companies who pre-funded us. You have to go through the same bit. You have to prove you're a bona fide researcher, and you have to be doing research which isn't breaching the consent we have of the individuals. As long as you do that, essentially, we'll be making access available to you.
Hi. We got to get to this side as well.
Do you want to pass it up?
No, you. Yeah.
Great talk. And I think there's a lot of effort that actually went into getting to this point. My name is Jay Kohler, by the way. And I perhaps have the undue advantage of having been trained in a country which, is a different country, and having to relearn some of the cancer, causative factors. We had to read the footnotes that says this changes when you go to North America. So it's fantastic, right? Everything that you're saying. So I'm still wearing a terminology hat at this point because there's a terminology, SNOMED meeting. So my question back to you is, what are your thoughts on the bias, the inherent bias in data? So for example, we deal with NHS organizations, helping them convert their lab test results into SNOMED codes. And they came to me and said, Jay, I just need a code for this thing because this is what we're being asked to report. And I have to tell them every time why they have to record it in the right way, not in the way they're being asked to record, right? And this causes bias in data. So I am not asking you for an answer, but what are your thoughts about avoiding this problem in the NHS? Because primary care data has got a lot of bias in some ways, if you want to think of it that way, right? I'll pass my question, but please share your thoughts.
No, it's very, very relevant, and I've been in many conversations over many years about the fact that data is driven by the mechanism by which it's recorded. Primary care docs are a great example. They record information which is relevant to the treatment of the patient. They don't record information which they may have, which is irrelevant. So I broke my hand 5-10 years ago. It was a pretty simple break. It was treated in a hospital. I've got a discharge summary as a PDF document in my primary care record. I don't have a diagnosis code because there's no ongoing treatment. There's no ongoing management. It doesn't affect me as an individual. But then you have in the UK also sort of systems which are imposing the doctors to do things which they weren't previously doing. So if you look at chronic kidney disease as a particular example, about 5-10 maybe years ago, there was a sudden epidemic of CKD, which wasn't real. It was just the doctors were being paid to code it. And if they get quality outcomes framework, which says if you have CKD patients and manage them, suddenly they all get diagnosed and they get recorded in the notes because it's checked. And their money is driven by what's in the notes. So there is a lot of understanding context, which is not just the sort of raw, go after the data and trust it to be the thing that you think it is. You need to understand why it's being recorded in the first place.
Sorry, there's one here and then another. Okay.
Hi, thank you. you. Diane Babsky, National Library of Medicine. So this parallels the precision medicine initiative going on in the US and our All of Us cohort.
Yep.
And one of the things that we've really, and I think this is going on here too, is not looking at them as patients, but as you said, participants, we're calling them partners.
Yep.
So what is the integration of, like, we've got wearables and other things, and how are you getting the patients or the participants involved?
So I think in multiple ways. So we started off essentially with a co-design activity with them. So we sat a panel, we did about 200 different members of the public initially, understanding what are the barriers to taking part in research, splitting that by socio-demographic groups, by ethnic groups, by age groups, to truly understand what is it that's stopping people taking part. We worked with them on the information sheet, we worked with them on the consenting process, we worked with them on the clinic visit. So there's sort of that level of actually working with the individuals who want to take part to design a process which works for them. And now we're trying to work with them on how do we do some of those things like integrations of wearables. What is it that they want to know? Is there information we can give back to them which will be beneficial to them that will make them want to take part even further? So there's, one hard job you have to do is recruit 5 million people. The second hard job you've got to do is keep 5 million people and entertain them and give them information that they want. And I give these talks to members of the public quite a bit, and I'll have half the room who go, "That's the wonderfulest thing I've ever heard. Please tell me all of the things that's wrong with me and what I'm going to die of." I get the other half of the room going, "That's the wonderfulest thing I've ever heard. Please never ever tell me anything that's wrong with me, because I just don't want to know. I'm happy just going on in oblivion and getting to the end of my life without knowing that." And I think we've got to manage, if you think about, and the way I often portray it is, if you think about an organization which is selling a product, very, very few organizations sell a product to the whole consumer marketplace. You have a target segment you go after, you work really, really hard, you get that target segment and you nail it. We're trying to deliver something to a segment which is everybody over the age of 18, across every socio-demographic, across every ethnic group, across every age group. And that's really, really hard. It's like consumer marketing on speed, of trying to think about how you do that segmentation, how you deliver something of value to each of those groups, and how you keep them engaged over time. And we're talking with Josh and the team quite frequently over what All of Us is doing and how they're progressing. So they're trying to do something even harder, of getting like half their cohort to be sort of white North American heritage, which is a really, really challenging task.
Thanks, Andy. We're going to have one last question, but I encourage individuals to reach out to Andy during the break if you have some follow-ups.
So my thought is that I'm over 50, so I have to have a checkup every year with my GP.
You do.
Who takes my blood,
Yep.
blood pressure, all those things. Wouldn't it be great if you could just then take that blood sample, be given to you?
Yep.
GP gets paid for it to do those things every year. So that must be your frustration in a way, that you're having to go and get the blood from people when there's so much blood taken already in the NHS. And could you just not have that blood and data?
So we are aiming to start in June or July a pilot through Department of Health so there's multiple ways you get blood taken. So one of them is health checks in the UK, which is everybody between the ages of 40 and 70 who is clinically well. So you can't have hypertension, you can't have hypercholesteremia to get a health check, and you can't have chronic kidney disease. They're trying to move that away from being a physical thing to being a digital thing with a blood sample. And we've got a pilot going with them probably in June or July. The challenge of actually working with primary care is purely a logistics question. There are 7,000 and a bit GPs in the UK, and there aren't enough blood samples routinely taken every single day for us to add extra tubes on and then collect them and aggregate. So there's a complex bit of logistics that we have at the back end, but we're trying to find, are there particular pockets like health checks, like community diagnostic hubs, which are now offering blood taking services across multiple practices in one central area, or working with hospitals who obviously outpatient phlebotomy sees thousands of people per day per hospital. And how can we do exactly what you say? There's and that's going to be a really key bit for us going forward. And as I said, the other one is sort of blood donors, people who are just turning up to give blood. They really want to help people. That's what they're doing. But it's trying to build those sort of connections. And over the past couple of years with COVID, it's been nigh on impossible to get the sort of attention of the service to really work with us on that. But that's the plan going forward.
And I'm told our very last question is from Dr. Charles Guttridge.
Thanks very much for your talk. My question, I think, is perhaps more aimed at this audience, because I think one of the things that prevents the adoption of SNOMED and its thinking in hospital practice is the fact that we don't talk about its opportunities for data analytics.
Yep.
And it'd be lovely to hear what you think about how we make that part of the learning program for the nation.
Yep. I suppose a few thoughts on hospitals. It is probably one of the biggest frustrations. So having run data groups for pharmaceutical companies, where mostly our medicines that we were selling, or the companies I was with, were in hospitals, the biggest frustration is you do not get the granularity of data at the hospital level of what's happening to the patients in the UK. So as I said, most of the data we get access to is ICD-10 or OPCS4 coded. It's an annual return for billing purposes, for want of a better description. And that's really, really hard, because you can't do the things you really want to do. And when you really look at the sort of opportunities in the UK, where you're looking at networks of local regional pieces, and Manchester's a great example. There's some wonderful work in Birmingham happening where they're integrating hospital primary 111 and 999 care systems together, where you can start to see the sort of richness of the data that's captured on the individuals. You get a real sort of insight into that patient much, much better than simply having they had breast cancer, which is, you know, essentially what you get. And actually the hospital episodes are really complex, because it's not always the right diagnosis, because it's a step through pathway diagnosis as you move through it. So I think sort of there are many, many examples where I couldn't agree more that actually having more granular data like you have in primary care from the hospital systems in the UK, either at a regional level or at a national level, would be hugely advantageous to the sort of, you know, types of research that we're trying to do at the sort of back end.
Thanks, everyone. Please join me in thanking Andy. And so we're going to roll right along. We're going to move into our community update session. This is a session that the organization has put together to really give everyone a grounding of the developments, achievements that have taken place in the SNOMED International SNOMED CT community since we last convened. This would have been in September in Lisbon. I'm not going to take up too much time. I'm going to get right to the subject matter experts who are going to share these updates with you. This is a bit of a map in terms of what we'll go through, and we'll just play with the time a bit. I will promise you a break between 10:30 and 11, not to worry, and so I'll manage that. But without further ado, Shelley, would you like to come up and deliver the global report? This is down.
Wow. Have to follow him? Like, oh, I'm like, we couldn't have did this first and then ended with that? My goodness, that was an amazing presentation. So I'm going to give you a bit of an update on what's going on globally in my team. For those of you that don't know me, I'm Shelley Lapon. I'm the Chief Customer Officer for SNOMED International. So what I my group does pretty much anything that touches the customer. So all our CRM leads, implementation, education, clinical engagement, vendor engagement, and implementation support now. So I'm going to give you a brief update on some of the pieces, and then some of the rest, and collaboration, sorry. The rest of the team will follow. And then some of the updates have been in some of the other meetings. So this isn't a kind of fulsome everything. We kind of picked and choose this time. And certainly I'm around all week if anybody has any questions, and I will point out who you can ask even more detailed questions to as I go along. So we're split up into different regions. So the Americas regions, which is Susie Wah, there she is. She's been busy, and you'll notice that we've got a bunch of new members. So Susie, particularly, and a warm welcome to Jamaica. And I believe Jamaica, hope maybe is on the line. They were certainly on the line yesterday during the member forum. So really excited to have them included. Her time's been spent a lot of time onboarding El Salvador, which, as you remember in the last meeting we announced, had came on, so she spent a lot of time there. And then every acronym you could possibly think of is going to be on these slides as we move forward, including she spent a lot of time working with Health Canada in their Canadian clinical drug data set. They're going to be using SNOMED, so we're pretty excited about that. And then as well, for those of you who don't know, the USCDI, which is basically the interoperability data elements in the US, it gets updated, it comes out of the ONC and it gets updated regularly, where they basically identify the data standards that would be used in different areas within the electronic health record. And SNOMED, Susie spends a lot of time watching where SNOMED ends up in that, and it continues to grow in the areas that it'll be used. So that's pretty exciting. She spent a lot of time working with some of our Central and South America potential non-members that potentially will become members, including Mexico. There's been a lot of activity there, as well as Brazil continues to have discussions. As you recall, they were a member and then they were not a member. Peru and Ecuador. So lots going on in the Americas area. It's a busy place, and certainly if you have any further questions, reach out to Susie. Then we have EMEA. So this is Europe and the Middle East and Africa. And we have those split between Europe is handled by Ian Green. It's over there. And Middle East is Nick Egerhas, and he's in Africa, and he's here. And so you would have heard as well, Poland and Andorra have become members. So we're pretty excited about that. We have been in discussions with France for almost over a year, I think. We're close. I think we're really close. There's some representatives from France sitting right there like, yes, we are. We're really close. So we believe that they will come on this year. So we're pretty excited about that. And I think there's been France representatives actually, we're in Lisbon as well. So they're already starting to be part of our community. We're excited. We're in discussions with Croatia and Hungary as well. As you recall, I think it was a year ago that the EU announced the 60% funding to become to assist in the membership fees, and so that is really poised some of the other European countries to join. We have been actively involved in some EU projects as well, and we're excited about that. So there's a lot, as you know, there's a lot of funding on the table to move digital interoperability forward across the EU. One of the projects that we are just putting our names in to be a part of is the X-Share project. I won't try and explain what exactly it is, but it's a consortium of about 27 different partners, including most of the standards organizations. And Ian Green is heading that up for us. They've asked SNOMED International to be part of that, and we're going to take part in it. I believe the proposal goes in this week. So we're very excited about that as well. On the Middle East side, you'll know that Jordan, UAE, Saudi Arabia are already members. Qatar has announced that they as well plan to use SNOMED CT, and they're just in the middle of kind of finalizing the procurement process around that. So we had some discussions at Arab Health with them, and they're quite excited to move forward. And Saudi, interestingly enough, some of the Australian members of our community that many of you would recognize, like Heather Grain and places like that, or people like that are involved in working with Saudi in moving their use of SNOMED CT forward. So we're quite excited there as well. On the Asia Pac side, Indonesia, one of our newest members, they're big. That is a big country. And so we are spending a lot of time on the onboarding of that. We've had some people that have done a workshop in Jakarta, and we're moving that forward. So a lot of excitement there. We as well have been working with Zaro and Kate on what participation in NetInfo that's coming up here in Sydney in July. There's a little pitch for you, for any of you those that you're looking at it. It's for any of those that you've been there before, tends to be a little more academic, but they're trying to make it more industry focused. So we're going to be involved, and we're excited about that. And that's Liera Tatuna, Asia Pac at the back here. So as many of you would know, implementation support is a service that we onboarded about 1.5 years ago. Alejandro and Kai are in there. They've all put up their hands if you have any questions. So we put this in place. It's been pretty successful. I'm going to be talking about some satisfaction results today at the GA meeting. Lots of online meetings, a few face-to-face workshops going on in Portugal, Israel, and Ireland, as well as we are now merging implementation support with the CRM leads as we start to do our onboarding for those new countries. I'm going to just point out a couple areas that they've worked on. So we've been working with those clinical reference groups. There's a bunch of participants of our clinical reference groups here across. Thank you for everything you do. Your work is really important in helping us move the product forward. And our implementation group has now working with them and putting out some of those clinical implementation guides and how the clinicians will actually use SNOMED moving forward. We're testing it with allergy and then hypersensitivity, and working with those CRGs as we put some of these kind of more uniform approach to implementation guides out. Translation. I don't know how many times we heard that yesterday in the MF. We hear you. We understand that it is a challenge for those non-English speaking countries. And it is a major priority for us, certainly in the implementation group and in many of our others groups. What we've done thus far is tried to merge a bunch of the information we have around translation, a lot of our guidance, and put it into a portal that makes it easier for people to find. But that is just a first step, and trust me, we recognize that we need to come up with some tooling that is easier to use, and Rory and I are committed to the implementation group to figuring out how we're going to do that moving forward. Post-coordination, do not ask me anything about what this actually means. Post-coordination guide and tooling, it is very complicated, and we have the first draft of the practical guide to post-coordination. It has gone out. We are looking for feedback on that, and we've also done a demonstration tool that will help on, kind of point out how you would use it. But we look to you guys to provide feedback to us on how we're going to be able to do this. I know it was on our to-do list for a few years. We've now just delivered it, and we'll kind of see where the community is at, how much of our community is actually going to be doing post-coordination in the near future, as to how many resources we'll invest in this at this point, because there is, as you would know, a ton to do, and we are 50 people. So that's in place. If you have any questions, Anne kind of led that, so certainly reach out to her. EDQM map and Simplex toolkit. So for those of you that were involved in the drug user group, one of the things that they said they needed was an EDQM to SNOMED map. And so that user group actually is the one that did it. This is not something necessarily that came out of SNOMED International Core. It was the user group that put that map together. And so we've published it in alpha and production versions at this point. If anybody has any questions about it, again, can probably reach out to somebody from the implementation group, Alejandro or Anne. They'll be able to point you towards it. We used our Snap to SNOMED tool, which is, again, we heard you when people were saying that we needed a tool to be able to map from our local terminologies to SNOMED, and vice versa. And we put that tool together with the help of our partners as are on this, and Snap to SNOMED is what we used in doing this particular map. If you have any questions, like I said, reach out to Anne or Alejandro on that. Vendor engagement. So this is Nick Egerhaus again. Want to tell you about a really exciting project. So you might have remembered that we mentioned that we wanted to enter into a project where we actually implemented SNOMED into a open source EMR tool. And we went around and we found a coalition called BOMNI. It is a nonprofit group that comes together, and they have a product called open MRS product that is mostly used in Africa. It's used in India a little bit. And we went to them and said, what we want to do is we want to put in SNOMED CT natively into the product. And so we are about 35% into that product. We expect it to be done at the end of May. And we've seen our first demo of it. It's pretty exciting. We're hopeful. It's like we said, it's going to be open source and available to those low digital countries. And stay tuned. I think October, you'll be seeing it really demoed and in our booth, etc., in Atlanta. So we're pretty excited about that. If you have any questions, you should ask Kai or Nick, are kind of leading it from our teams. Lots of other stuff going on in vendor engagement. We've probably spent so I've been here 9 years. I think, Nick, you've been around for 7, maybe 8, 6. Okay. So it seems longer. No, I'm just kidding. So, when we first started on the vendor engagement side, we were really focused on, the big EMRs like Cerner and Epic and all of these. And we've now kind of transitioned our vendor engagement strategy a little bit to start looking at those startups, could we get SNOMED talked about and included early on? Because Cerners and Epics, yeah, they have SNOMED in them, but any of those more established legacy EHR systems, it's tough. They've already built their architecture. How do you get them to change? It's it's like moving, Noah's Ark kind of thing. So we started to focus on startups a little bit more. And again, if you have any questions, you can give Nick or reach out to Nick. But we've started to have some discussions with some startups and some of these incubator projects and where we might be able to get involved. The last thing I'm going to talk about is SNOMED certification. So one of the things that we've talked about for probably about 4 years is whether we could actually start to develop certification requirements for vendors that potentially our members would be able to use, or do we even potentially SNOMED International look at putting a certification process in place. So we're just starting that up. We're using some of the artifacts that we had previously, like the RFP core vendor requirements that we worked on with the members a few years ago. And we're going to start to put that forward. I'm hopeful in October that we have something to bring to the community to get input on, probably at the member forum. And then we'll move forward from there and see what makes most sense for the organization. Lots else going on. I'll just talk about one of these. We have an ongoing project going on with Apple that we're hoping we will be able to announce before the end of the year. We're pretty excited about that. And then just working with some organizations like MITRE and them as well. And that's it. I have no idea if I used the right time.
No, you perfect. Thank you.
Thank you.
I'd like to invite Susie Roy and Jane Miller up to the podium, please, to give us an update on collaborations.
We're a buddy team, so it's so exciting to see everyone. Good morning, everyone, and hello to everyone online. So I'm Susie Roy, or Susie Roy, or Sujan Roy, depending on which one of my ethnicities I'm going to wear for that day. And I'm joined with my colleague,
Jane Miller.
And we are the collaboration team. And we're really excited to talk to you a little bit today about what we do in collaborations. So we really interface with our collaboration partners. And who are our collaboration partners? Of course, SNOMED International, we have a wide range of stakeholders. Primary stakeholders being, of course, you, our members. But we also interface with, policymakers and clinicians, implementers. A large group is also our collaboration partners. And those include various standards development organizations, as well as professional organizations such as the ADA, AMA, and many others. And so just a large part of what Jane and I do are interface with them, but also in addition to ensuring that we have collaboration agreements, MOUs, and other sorts of licensing arrangements, we also deliver products and various deliverables. And that's in collaboration, of course, across the many lines of business within SNOMED International. So usually Jane and I are up here and we give you a huge bowl of alphabet soup. And we're not going to quite do that today, but for those who are hungry for that, we have included all the acronyms up there for you so you can get your dose of it. But of course, we're going to give just kind of a high-level overview of a couple of collaborations that we are focusing on at the present time. But of course, all of these are still going on. We're pretty busy. So if you have any questions about the Medra maps, or if you have any questions about any of the terminology integration that's occurring with any of those that are highlighted in purple, or any of the others, just come up and find us and we'll rattle off all of these acronyms, as well as all of the maps and free sets and all the content integration that you could ever want.
And it won't be boring.
No, it's actually a lot of fun. So again, we're kind of the ones who provide that linkage between SNOMED International and these other international organizations, whether it being the professional organizations or with other standards development organizations. And we do this because it is one of the key priorities that were identified within the strategy. And now being in the middle of our 5-year strategy, SNOMED CT continues to be that hub. And we're able to do that because a number of years ago, we developed a collaboration framework. And that kind of formalized our process in how we determine who do we collaborate with and how. So that was really a kind of phased approach. So we do a lot of evaluation before we enter into any sort of partnership. And during the partnership, we continue to kind of evaluate. And then at the end, or towards the end of it, we evaluate it again. And this is really to ensure that anything that we are doing with any of these partners really provide value and benefit back to all of our members. So we're not just entering into, a nice little relationship with an organization, but we actually have, key deliverables that we want to bring out. We want to make sure that we have that map that's really going to help a particular member country in their adoption and implementation of SNOMED CT to get the resources and everything that they want. So again, the collaboration team, we coordinate all of those collaboration agreements, and we provide and ensure that we have those deliverables with our partners. And we also identify various international standards that we can interact with and partner with. And we always make sure that those are based on use cases and requirements that come from you, our members. And so what I kind of wanted to do was just kind of give you a couple of examples of some things that we're doing right now with current collaboration partners. So one of our partners, or one of the organizations that we work really closely with, is the Joint Initiatives Council. So the Joint Initiatives Council is comprised of a number of standards development organizations. I'm not going to be able to list them all off my head, but IHE, HL7 International, ISO, TC215, and a number of others, including SNOMED International, are part of the Joint Initiatives Council. So it's a group of standards development organizations. Dawn is our chief executive, who is the representative for SNOMED International at the Joint Initiatives Council, and Jane and I join him. But the Joint Initiatives Council is really excellent because it is a group of these standards development organizations showing that we all work together. And recently, a number of new standards development organizations, ITU, IEEE, and ICPA, have also joined the Joint Initiatives Council. And again, this is a really great way for all, and Regan Streif is there, I know Marjorie is here somewhere. We work together to ensure that we're able to continue to work in different ways on various initiatives, on different projects, global projects, to ensure interoperability amongst the various standards. One of these projects is the International Patient Summary. So this has really been a successful project that is a collaboration of 5 different standards development organizations, including HL7, IHE, SEN, and ISO, and SNOMED International. So we've reported a number of times, SNOMED International, we create the International Patient Summary free set in collaboration with HL7 and SEN. And that ensures that any sort of content that people need in order to implement the IPS, they're able to do so freely. And of course, for members, we also make a number of resources such as the IPS rough set. So this cross SDO group is excellent because we all work together to ensure this alignment of the various IPS artifacts. And we're able to do that because we are part of the team that is working on the maintenance and coordination process of the IPS. Another thing that we're doing with the Joint Initiatives Council is we are actually working very closely with the GDHP to join as a member of the Global Digital Health Partnership. So the Global Digital Health Partnership, and I know a number of you, I was just noticing, is a group of 33 countries and territory governments and 3 international organizations who all work together towards the global digitization and trying to talk here, and implementation for global health. And there is a large cross between SNOMED International members and the Global Digital Health Partnership members. So for us, SNOMED International, they were identified as a key organization that we want to work with. But of course, because we do have the Joint Initiatives Council, which is a cross of all these excellent international standards development organizations, we see that there is huge benefit if we join as a JIC, as a council, as a group of executives with the Global Digital Health Partnership, to ensure that there are ways in which that we can partner and work together to ensure that any initiatives and projects that these various governments are working on, that they have the ability to have coordination and collaboration with all of us SDOs. And so that's one thing that we're working on, and hopefully in the next coming months, we'll be able to announce that we have a partnership between JIC and the Global Digital Health Partnership. And is this one you know?
I know this one, yeah.
Yeah, you can do this one.
Okay,
yeah.
Thank you. Thanks, Susie. We've already touched on EDQM, but what I want to talk about is some of the key current activities of new collaborations and we've got the alphabet soup, as we say, but also ones we're exploring at the moment, because actually we want your feedback on some of those. We started yesterday with the member forum. So again, as Susie's already said, come and find us. So it's what Shelley's already said. EDQM, we had a collaboration with EDQM because we obviously have to put those in place as well to produce our products. The implementation team have worked with a drug group to actually produce this map in collaboration with EDQM. So that's gone out the door, I think, or is about to go out the door as a production release. We've working very successfully, Jim Case. I think this is the key thing. It's not just the collaboration team, the two of us, it's the whole of the organization. And we're both very bossy and everything like that. But everybody works together on all of these things. It is, oh right, thank you.
We are.
But this is about the organisation and the way it works. It is not about just us. And so Jim Case has been working excellently with the AJCC, where you have an agreement to use some of their content. And he's tapped on the door and said, can we use a bit more? And so this is about what it's all about. It's starting the process, going back to that terminology integrator. And what I'm seeing, and I've been going to ISO meetings for a little bit too long, probably, TC 215. And what I'm seeing is an increased level of getting down into the terminology level, the data level, which is actually what our speaker was talking about earlier, getting the data levels right. And that includes terminology. And what I'm seeing is, as Shelley said, well, how many people do we need to go to these meetings? Well, actually, we've got 4 or 5 groups now, which are down at the terminology level. And so it's exciting change, in my view. So it's worth at this time investing some time in that, because the terminology level is going. So coming to the ones now, and we are on the alphabet soup. We've been approached by OpenEHR. We've had an agreement with them for quite some time to actually use SNOMED in development, and they've had an agreement to do that. They want to do some more. So these are all things we'd like to hear from you and the community. What are your thoughts on what do you want to see SNOMED and OpenEHR doing? GS1, we're at the review stage. They support the supply chain, and there is an interaction. There's already been an interaction with their global trade item number, GTINs. In Australia and other countries, they link the GTINs to SNOMED. So we did some principles for that. What else do we need to do with GS1? As the supply chain comes very, very close to clinical and wants to do links to the clinical side, Where does SNOMED need to be? Oh, trust me. Whoops. ICCBBA. Now, is it 2 A's or 2 B's? I don't know, because the other one had 2 A's. Yeah. But there we are. Anyway, the most important thing is, again, they've just joined the JIC, and they would want to actually, we're exploring with them that integration between what they produce, which is ISBT 128. Goodness gracious. And that is a global terminology for blood products. And we have over time had quite a number of requests to actually look at this, and that we need a link to it, because it is used globally within healthcare environments. So let us know. Interi, as many of you know, we've just handed over, finished a project, the first stage of a project looking at social care globally. And the content team are now working on updating SNOMED accordingly. Although so much content is already there. But out of that has come a piece of work which was already happening within the implementation team, looking at work with Interi in Australia. So we've started this discussion with them. This has opened up the box of assessments, etc., and how we deal with them. And so we're having early discussions with them about how we might work together in the future, and how they might use SNOMED in where they are wanting to get electronic and to link with primary care and other health services, as opposed to standalone units for older people, for example, long-term care and things like that. So there's opportunities out there for us as well. So we want to hear about those who are using it and whether this is a place we need to be. GMDN, we're up for renewal with GMDN, our colleagues there, and we're meeting with them on Wednesday morning. They have a new chief executive, and when that happens, we all know that this is an opportunity to review and look at things, which is exactly where we're at anyway. And at the moment, we have devices from them. We have a feed of devices so that our products can be aligned where they're in scope of SNOMED CT. Where do we go next with GMDN? And the global medical device nomenclature. So, just picking up on this slide here on your right, we have, to counter that in Europe, we have the mandation of the European Medicines medical device nomenclature. And so this is where we have to balance. We have to prioritize, because we will have to have a link to that at some point, because that is mandated for use across Europe for the identification centrally of devices. On the left-hand side, this is a request from our content team. They'd like to hear from you. We've had a long-term implementation of ICDO through SNOMED, and they're looking at the moment in that team at moving to 3.2. What are your requirements? Yesterday, there was discussion in the member forum about 3.4. So do we go straight from 1 to 4, or do we go to 2 first? We need to hear your views and what your requirements are. Oh, is he in next?
So what
happened to the end slide?
So if you have any, as you saw, Jane and I, we have a lot of current collaborations, but also we are seeking requirements and use cases, because we want to make sure that what we're going to enter into next and what we're going to deliver is really going to be helpful for you, our community. So please find us. And again, if you missed any of the other alphabet soup thing that we showed there, just come and find us and we'll be able to talk to you about some of the other collaborations that we have. Thank you. Thanks.
Thank you.
Thank you, collaboration team. We're going to take a pause now, and we'll start off with Ian when we reconvene at 11 o'clock post break. Thank you so much. Okay, if I could ask everyone to please take your seats, we're gonna get started again. Please bring your friends from the reception hall as well. So we're going to kick things off for the second part of the community updates with Ian Green, who leads up our clinical area as well as the relationship manager and executive for Europe. Ian, here you go.
Good morning, everybody. So my name's Ian Green. You know me from where Shelley said about me covering Europe, but I also cover the clinical engagement side with my colleague Jay Miller, who you met, and Dr. Charles Guttridge, who is, well, he's just Dr. Charles Guttridge, really. And the three of us, we're kind of the dynamic trio, I guess. So to give you just a quick kind of overview about what we're doing with clinical engagements, what we're doing with the clinical side of SNOMED. The way we choose to reach out to and get clinical input is through clinical reference groups and clinical project groups, of which at the moment we have 8 groups which are up and running and 3 clinical project groups. What those groups do is essentially focus around discussions on general clinical topics, but also specifically around areas of content which need either review in terms of the content we already have, or looking at gaps in the content. So filling in gaps or looking at new requirements from a clinical perspective. One of the new groups which are up and running now is eye care. So originally we were going to call it the ophthalmology group, but we didn't want to exclude optometrists. So it's now become eye care rather than ophthalmology. But that group, firstly, is up and running. It's also gained a lot of interest from a global perspective, so particularly from Europe, particularly from North America. If I look where we're going with some of these groups in the future, the big area that's generated a lot of debate is around neurology. So some of you will be aware clinically there's quite a lot of discussion internationally around Parkinson's. So the focus of that group initially may well be Parkinson's in some form or another. But neurology will pick up neurology, it'll pick up neurosurgery. The other area, which is almost fundamental to all of our members, I guess at some level or another, is public health, which is really picking up the secondary use of SNOMED data and getting the most out of it in terms of analytics, in terms of secondary uses and analysis. The nutrition and dietetics group is actually the project group. So we had a group looking at the nutrition care pathway. So that's morphed. So rather than a project group, that'll be an ongoing group now as a clinical reference group. And then the work which Jane Miller's been leading around social care, we're pulling together essentially an SME group, but there'll be a group focused on social care going forwards and looking at where we develop SNOMED in those areas going forwards. Don't worry about the long confluence, but we have a confluence site for clinical engagement, which tells you a lot about clinical engagement and what we aim to do, but it also gives you a link in the directory of all the clinical groups. If you can't remember the confluence page, just remember snomed.org/clinical and it will take you there. Just ignore the pictures. We do need to update them, I think. This is a bit of advertising, I guess, from my perspective. So all the clinical reference groups that we have on Confluence, you have the functionality to actually follow and watch the individual sites. I'd encourage you, and by you, I mean you and all your network of clinicians, even if you don't want to be actively part of those groups, that watching them is a good way of keeping up with the discussions that are going on. You get an email when there are changes made to those pages. It's definitely worthwhile doing just to keep you informed and any clinicians that have an interest in those areas. So a bit of PR, but please, that would be really helpful. The other couple of things that we do, so we have an internal clinical database. So one of the challenges that Jim has and the authoring team is when we have content requests that are particularly unique, we need some clinical inputs into some of those. And you're looking at some very specialized areas that we're going into in terms of content now. So we keep a clinical database of clinicians who've agreed to help us. That database is not open, so before you ask, you can't have access to it. The people that are on that database have given permission for us to keep their details and for us to reach out to them when they're needed. If you know of clinicians who are interested in being part of that, just drop me an email and I'll pick that up with them individually. In terms of conferences and presentations, so Charles and myself now have a kind of regular gig in some ways with Karolinska. So Karolinska's the university in Stockholm. They run a master's degree on clinical informatics, and we do a 2-hour workshop as part of their MSc course, looking at clinical analytics and really looking at practical examples of how SNOMED supports clinical use cases. So some of you are familiar with running through things like the foundation course and the general presentations on SNOMED. The workshop isn't that. This is more about real life examples, if you like, and working through some of the challenges and some of the processes and benefits of doing that. It's obviously reasonably popular because we keep getting invited back. I've tried to avoid it, but we can't. The other thing this year, particularly for those of you in Europe, so MIE is Medical Informatics Europe, which is in Gothenburg this year. We're running a workshop there along the same lines, so looking at clinical analytics, looking at leveraging expression queries, and really how SNOMED fits into the whole clinical decision-making. Part of that conference at the same time, they're running Vitalis, which is the Scandinavian Informatics Conference, Health Informatics Conference. All being well, we will be doing a presentation. At the moment, it may be on nursing practice, but who knows, there's a lot of time between now and when we do the presentation. So it's kind of work in progress, if you like. The big thing for us, and certainly for Jane, Charles and myself, when we set this up, we didn't quite know what we were creating, but we've created a group called the Clinical Leads Group, which takes the chairs of all the clinical reference groups and project groups, and it meets every month. It enables us, firstly, to share between the leads work, so it allows us to share work between the groups, which is really important. It also gives us a forum from SNOMED International to almost run things by that group and get their clinical opinions, which is also valuable. It helps when we can focus on specific projects. So one of the things we've looked at between the groups is working with Kelly and her team around communication activities. So how the individual clinical reference groups can look at leveraging social media and other avenues to highlight the work that they're doing and increase the membership of the group ultimately. The clinical focused implementation guide Shelley mentioned earlier, so I'm not going to spend time on that other than to say the allergies guide now is almost finished. So that's been work between the allergies group and the implementation support group. So that's in its final stages and will be coming out very shortly. The Cancer Synoptic reporting group is doing the same thing around their implementation guide. That will take a bit longer because they started later. But that work's already been, the implementation side of it is already being picked up. So before this meeting, a couple of us went down to meet with some cancer clinicians down at Adam Brooks at Cambridge. They're looking at taking that work forward with Epic, so with their LIMS provider. And that's it. Any questions? Yes.
So the social reference group you were talking about, are they going to be concerned at all with healthcare equity?
Good question. Well, if I take a purist point of view, then all of the clinical reference groups are interested in equity. You did ask. Not specifically, but I know what you mean. But yes, in terms of the equity thing, yes, that does come into discussions, but we're not having a separate group looking at health equities. Although maybe we should.
Thank you, Ian. As you can tell, we're not having another break right now. I'd now like to invite our Chief Information Officer, Roy Davidson, to come and share some of the recent developments in the products and services space. Thank you.
Got a nice big green and red button, so you can't go wrong. Good morning, everybody. I'm here to talk about products and services. Most of you heard me speaking a lot yesterday, so I won't speak too much today. I think if you remember last community updates in Lisbon, we had a timer and it was a bit pressured and we had to do short slides. So I thought I'll just do one slide and that covers everything we do. There's a lot behind it, but then I realized, no, that's kind of cheating. So I'll go on. And I'll cover some things, but really, you know, I'm here, I'm standing on the shoulder of giants, to be honest. So I'm just talking up front. But the first thing I want to talk about, because we didn't really cover it in the collaborations, is the work we're doing with Loink, because that's kind of one of the really exciting things we're doing. And it's great to see Stan, Isa, and Marjorie here from Regent Street, who we work closely with. We talked about this back in Lisbon, and it's moving forward. And that's the really nice thing. We've got some stuff done. The team's been working very well together. Some of you will have seen there's already a sub-ontology browser on the alpha version of this. There's some discussions about the wording of calling it a sub-ontology browser, but we'll leave that for a philosophical discussion over beer. So what we've done is we took 100 terms from the Loink team, and we're trying to find a way, can we produce software to do this in an iterative way? Can we repeat it so that we don't basically have to manually do work in the SNOMED extension? The aim being that the master source is always going to be the Loink release files. If we might start making modeling changes in this Loink extension, then the two products go like this, they diverge. So we want to make sure that this is almost an automated process as far as we can possibly get it. We're very early on in the process. We've had some interesting long discussions down into the details, and there's still a lot more to go, but we're looking for those patterns we can see in the Loink terms. What can we replicate into the SNOMED model? It's looking very positive. This is going to be a long journey, as we know, but we are really hoping as a joint team to get something out to the community to review this year. We do believe we can get more than 100. 100 of the proof of concept does the way it does work, it does. But now can we do that at volume? And so that's the thing we're going to be working on next. And we've got a meeting, a 2-day meeting in Montreal with the rest of the Regent Street team and the rest of the SNOMED team to walk through that. So that's a really exciting thing. You know, we keep on talking about it and we shouldn't forget it. I think it's really opening up a whole load of things that we couldn't do before. All the expertise from the Regent Street team, giving us that lab and observables and pathology content that we just don't have. So really exciting. We'll keep getting excited about it for the next 2-3 years and longer. After that, so a bit about the software. So what's been going on in the software? Again, there's not a lot on there, but actually there's a lot going on and a lot behind the scenes. The first thing to talk about is the new version of the reference set tool. It's taken a bit longer than we'd hoped, but it's going really nicely. We're in the right place. We'll be opening up for testing for managed service member users to start with. Once we get that feedback, then we'll open up to a wider audience to kind of get more feedback and keep it working. The main thing about this new tool is that it integrates directly with our authoring platform, which feeds into our frequent releases to make that easier. It's less of an issue for us on the international level, but in the managed service, we have some members who have more than 100 reference sets. So when we start to do this frequently, it becomes a lot more work for everybody. So we're trying to, again, improve that whole process. We've done some more work in the software about providing more self-service to managed service members, again, allowing them to do their own upgrades, which means upgrading to a new version of the International Edition. That takes a lot of work off our internal team, but also means that the local users can make their own choices. And there's a whole load of other things we've done. I mean, there's been God knows how many tickets that have been supported and releases for managed service members, monthly release of the international team. So there's a lot that goes on in that software team, and most of them aren't here. Some of them maybe should be listening online. So I'd like to thank them very much for all the work that they do. They go above and beyond all the time. Going forward though, so some of the stuff we're doing is actually linked to the Loink work. So one of the things we want to do with the LOINC extension is to have the LOINC IDs alongside the SNOMED identifier. In RF2, some of you know there's a file called the identifiers file that's never been used. And Guillermo informed me the other day that actually it was created for LOINC in 2006, but we never used it. And now we're going to use it, which is great. Forward planning, there's strategy for you. Other things we need to do with the LOINC extension is to extend the MRCM. It's going to be a different MRCM, but we need to extend it. There's only one other instance we've come across of extension to the MRCM, and that's with the Australian content. So we need to be able to support that anyway. So we're doing this for LOINC and the Australian NRC who are on the managed service as well. And multiple module dependencies. Again, it's linked to what we're seeing, where we see the content going. You know, we want to do more of these types of projects like the LOINC work. So community content you may want, you may not want. But instead of it just being in the international edition, you need to start creating these kind of jigsaw pieces of how do you put it all together in one place. And so one of the discussions this week, and you'll hear over and over again, is about moving away from extensions to editions. So the implementers don't have to work out where they need to go to get everything. They get it in one place. Of some countries here, obviously the US has an edition, Netherlands has an edition, so it's not unknown. It's just there's a cohort of countries who do extensions and a cohort that do editions, and we're going to have that discussion about moving to editions, whichever side I said that on. And so there's some software we need to do to improve that, and that's some of the work we're doing this year. We're doing loads of other things as well. We look to see how can we improve our capacity. We work with we outsource some of our software. We're working with a supplier out of Atlanta called Teliant Systems. Most of their development capacity is in India, but they've been helping us refactor the component identifier service, but they're also starting to do this for MLDS. Most of you use MLDS. It's been around since 2015. Never broken, just works, it's great, but some of the technology is getting a bit old, we have to update it. But one of the things we are going to add to that, and again, you'll hear more about that this week, is the ability to actually use a syndication feed. So one of the things those who are Onto server users know well how Onto server uses a syndication feed. And so we wanted to leverage the work they've done, but do it in such a way that any terminology server could use that syndication feed. So we've been working with the team from CSIRO, from other suppliers who've been involved in that to get feedback. And we have a version 1 of that feed, and MLDS is going to publish to that as well as the normal page. So that means that if you have a terminology server that's compatible, it will automatically download the latest release and do the upgrades. So exciting stuff happening. It's kind of behind the scenes, but it all moves to easier deployment, easier adoption, people using terminology servers, not using RF2 files floating around. So all exciting stuff. Well, to me. Release management. I think is Andrew here? No, is he? Oh, he is. Normally he's not here doing releases. So yeah, Andrew, obviously, as you all know, is the unstoppable release machine. Lots of releases gone out the door since our last meeting. The big one, as Don mentioned, in the past, the IPS terminology. That's been really popular as a sub-ontology of the IPS content. Our monthly releases, the international edition, we now don't talk about it. Well, I do, but we don't talk about it because it's just embedded. We all do it. And we're starting looking to move managed service members who are interested to a more frequent release cycle as well. We've got more derivatives out of the collaborative work that that Jane and Susie were talking about. The EDQM map comes from the implementation team. Then we put it through the factory floor. And the Medra maps are being worked on to go out in the next month or so. So go to TRAG to find out what else is going on, the extensions versus additional discussion, but also a discussion about moving the international release to the 1st of every month, not the last day of every month. Purely historical decision in the past, but as we move to monthly releases, it's not always the 31st, it's the 31st, the 30th, the 28th, the 29th every 4 years. So it also starts to clash with some local releases. So we want to try and move that to the 1st of the month. It doesn't sound like a big thing, but actually it's one we need to discuss, get your feedback. All going well, we'd like to get onto that this year, hopefully around August time. And really just to finish, because I'll hand over to the rest of the team. I'm pretty sure I've got, every year I do this, and every time I forget one person's name, I'm pretty sure I've got everybody. Monocle do me. But so, but yeah, I just really, as I said, I'm here to thank very much the products and services team because they do an amazing job to make sure that SNOMED CT product is what it is the high quality it is, and gets out the door every month. So like to thank that team. And with that, I hand over to the real boss.
Chief Terminologist, Dr. Jim Case, we'd like to welcome you to the podium. Share with us content strategy and our roadmap. Thank you.
So good morning, everyone. Thank you for all attending. We're glad to see everybody in person again. One of the key strategies that we have currently within SNOMED is called the Quality Improvement Initiative. And that's been going on actually since 2018. And the initial focus was on improving the structural consistency of SNOMED content. There was a lot of inconsistency in the way content was modeled in the past, and we found that if we wanted to apply automated tools to do content management, it was much more difficult to do that with these inconsistencies that existed. And so back in 2018, we decided that we would take a focused approach to improve that structural consistency with a review primarily on how content within the same area within SNOMED is being modeled. So it is a major objective in the SNOMED strategic plan. And while the structure is the primary focus in terms of reevaluating the content, oftentimes when you do that restructuring, you find that there's also some clinical issues that need to be resolved as well. And as we go through this project, we're finding that after handling the low-lying fruit, that there's more of a need to address that clinical quality as we go through and update the content. So we had been moving relatively rapidly through the first couple of years of this in terms of fixing the content, and since, as I mentioned, the low-lying fruit has more or less been handled, we're running into areas that are a little bit more challenging for us, and so the progress is not quite as fast as we would like it to be, but it is progressing, and that's something that we like. We focused initially on the clinical findings area, since that's the majority of SNOMED. We had some input from some of our members that they would like to have procedures evaluated as well. So beginning in late 2022, we started focusing on the procedures area as well. And so this is just a list of some of the areas that have been addressed since the meeting that we had last September. And we have a number of topics that are areas within SNOMED that are continuing to be addressed. And the progress has been very productive in terms of improvements of the overall hierarchy and taxonomy. And we are hoping that it's being visible to our members as well, as the improvements in the taxonomy have provided them with some benefits as well. So this is just a quick overview of some of the statistics to give you an idea of the scope that we're dealing with. The clinical findings and disease area, which are all in the same hierarchy, is over 115,000 concepts out of the 350,000 concepts in SNOMED. And so we're showing progress in terms of the number of new content that has been added during this time. So the QI work obviously is not all the content team does. This is what we do, in quote, in our spare time, as we're trying to address the rest of the content needs for the community of practice. In addition to the formal QI project, we also have internal quality improvement activities going on. We're currently doing a comprehensive review of surgical actions. As we looked in the procedures hierarchy, we found that there was some possible duplication, some ambiguity in the way that procedures, especially surgical procedures, are being modeled. And one of our new content members, Victor Medina, is a surgeon who has brought a lot of insight into the review of this type of content. And so we're doing this comprehensive review. After that review is done, we'll apply everything that comes out of the revision of the surgical actions area to the procedures hierarchy. We're also doing a revision and restructuring of the primary and metastatic morphologies and disorders, which is a huge task, since that's the origin of SNOMED was in pathology, and so that's a substantial component of what we have. There was an application of a new at-risk model that allows us now to sufficiently define risk content within SNOMED. And the enhancement of the AGCC content that Jane mentioned before was based on member content, member comments. And one of the things that we have identified in this process is that AGCC has changed the way that they publish their revisions to their allowable values for staging. That instead of publishing a full edition, they now publish chapters based on the organ system that they're reviewing. And so out of the 9 or 10 different areas, they've currently published the 9th edition in 3 of them, and they're anticipating additional revisions as we go along. So this is going to be an ongoing relationship with AJCC to maintain the allowable values within SNOMED. And then clinical quality review in terms of currency and accuracy. We're going to be putting together a document that outlines the processes that we use to ensure clinical quality within SNOMED, so that while there are a number of ways that clinical quality can be assessed, there's not one overarching metric that we can use within the terminology to say SNOMED is of X quality. And so by outlining the processes that we use, we'll be able to give some assurance to our members that most of what we do has gone through a relatively rigorous quality assurance process. So lastly, I just want to go over the editorial advisory group. The editorial advisory group is primarily a group of members from the community of practice that give advice and guidance to the content team in areas which have been proven to be difficult for us to come to internal consensus on. We have weekly content meetings. Monica's going to go over a number of the activities in the content team. We have weekly content meetings where difficult editorial decisions are brought to the group. And at some point, we just can't come to a consensus on that. And so with that, we seek outside support, sometimes going to the clinical leads group of the database that Ian mentioned before, where there's a reference to subject matter experts that can provide us some input, but also the editorial advisory group is comprised of people with extensive experience in the use, implementation, and actual construction of content within SNOMED. So some of the things that we've been looking at over the past 2 meetings, we've only had 2 meetings in September because vacations and the holiday season got in the way of a lot of this stuff, but we are looking at inactivation of the navigational concept hierarchy. That is going to be going out for further consultation. We provided an inactivation of delivered and not delivered concepts. These are all classification-derived concepts that don't really provide much additional information in active clinical records. And then we're looking at a revision of the history and past history temporal context values. This is in the situation hierarchy, where we have a number of concepts that it's unclear what the ambiguity, or it's unclear due to the ambiguity of some of the temporal contexts that we have, whether or not they're actually representing what they're supposed to be representing in the terminology. And then there are a number of other topics that we'll be discussing at the EAG meeting, which is tomorrow morning. That meeting is open to observers, and so we would encourage people that are interested in looking at how the sausage is made, that they would come to that meeting and join us.
And for some more context on content and mapping, here's Monica Harry.
And I'll probably not be able to work the buttons, but good morning and welcome everybody. Nice to see everybody here. And to those online, welcome. So really, oh, it's nice this is here. I'm glad I brought my reading glasses up now to be able to see. So the work that we do is driven by members, and it either comes through the content request system, which you're all familiar with, I'm pretty sure, and or through Jane and Susie's activities and Ian and the collaboration team and the customer team in terms of identifying areas of content that we have to consider for to add to SNOMED. So some of the projects that we're working on at the moment, the drug content analysis project has launched, and that was really driven by our so-called drug extension user support group, which is when we realized that people were beginning to build drug databases, national dictionaries, and needed help from us in terms of implementation. And we heard from members that there were several things that were not quite right in SNOMED, and the big one really was missing content for clinical drugs. So we decided, well, some of that already exists in national extensions. Why don't we get together and share the content that we know is already out there and decide, is it international? Does everybody agree on the name? Do we have an authoritative reference source? And should we add this to international? So we've started with the anti-infectives, which was decided by pharmacists, not by me, as being the most logical place to begin. So we've done that first pilot project, I'll call it, and with the help of Peter Williams and Technical, we're hoping that we can do much of it in terms of auto batch updates. But we obviously will have to do review. Some of the modeling won't be identical and we have to align it. So it's going well. It's actually based on the next project, which is microorganism. We took a similar approach to microorganism whereby we knew that content was out there. Some countries had it. And so we decided to get everyone together in a forum to share their content and then agree on one of the things that's always, I'll say it's not really contentious, but something to consider is the effective date of concepts. So we have to make sure that everyone's in agreement about if 3 countries or more have some content, whose concept gets into the release, because the ones that don't are going to have to change their IDs, et cetera, et cetera. So it's straightforward once you've all agreed on what the process is. So we're going quite well with that. Morphology, as Jane and Susie mentioned, we're asking members to tell us how much work they would like us to do on the morphology and ICDO versions. Now, we thought we were going to be looking at 3.2, but I'm hearing 3.4. Yeah, I'll hear more about that later, I'm sure. Anatomy is ongoing. Anatomy is probably the most challenging and I'm going to say most important. It underpins everything that we do. Certainly for procedure work, if the anatomy is not correct, the procedure concepts just don't make sense. So that's, if you can imagine your body and systems all flow into each other, they're not easily separated. So it's a big challenge. And Yongshan Gao heads up that project and does really good work with a couple of physicians that have been working with us for a few years. So that one's going well. And then substances, that's, well, so the substances as they were all they were classified as per a role, and we are now moving those roles from substances and moving it to products, which sounds as if it would be simple, but it isn't simple at all. So just so you know, there's a team of us, there's 10, and we work on the quality initiative. Everybody has a piece of that work to do. And then depending on people's, I'll call them specialty areas, they each get assigned a project or a piece of work. And we move people around as well so that they get more cross-section of work to do. And collaborative projects, we have an agreement with Kaiser Permanente. They donate content and we, the CMT, Convergent Medical Terminology, that is, and we add that to SNOMED. We're working with the International League Against Epilepsy to update the seizure content for epilepsy and epilepsy disorders. Important point there, I think I'd like to mention, because it's something we struggle with, is that very often specialists come up with new terms, but it hasn't filtered down to the general practice level. So I think change management's a big part of that too, in communicating the changes and why it's not just SNOMED changing it, it's that the experts in the field have decided that things have to be aligned differently. And then strategic priorities, some of these were touched on earlier, but social care is a big one. There's been a big gap analysis that was done over the last, I'll say, 2 years, and now we're at the point where we have identified content. Some of it, as Jane mentioned, exists, and we have to revamp or remodel it, and some of it is net new. Geez, you need water, I'm dry. Sorry, I'm not complaining. And then cancer synoptic, that work's ongoing, and thanks to the doctors Campbell, who've done a big piece of that work with the pathology group. And then traditional medicine, we had that as part of our strategy to build a framework. And we've basically, I think I'm right in saying, finished that as far as we're going to go at the moment, but we actually are still working with India and a couple of other countries in advisory capacity to help them set up their content for that. And then mapping, don't forget mapping. Everything we do really impacts the maps. So the maps we maintain and update ICD 10. ICD 11, we had a pilot and now we're going to pick it up again and start doing more mapping automated with an outside company and see how that goes. So that means our mapper then have to sit down and do the quality review. So that's quite a lot of work too. Orphanet ongoing, we have a content and then we have a map that goes out annually. So there's ongoing maintenance. Similarly with Medra, it's a map and content ongoing maintenance. And I don't really know why it's there again, because it's only one project. And then I mentioned ICDO 3.2 under review. I think that's, yeah, the last of my slides. Thank you.
Thank you, Monica. And now I'd like to invite Terence Sherd up to the podium to provide some information on the organization's technical infrastructure and approach to managed service.
Thank you, Kelly. Welcome, everybody. Welcome, everyone online. Terence Sherd, the Technical Operations Manager. So as the title suggests, I look after one of the slides that Rory put up there, keeping the lights on. I look after the operational team that keeps the lights on. And I also am responsible for looking after the managed service as well. So to start off with the technical operations stuff, in Lisbon, we announced that there's been a huge change around the licensing for Atlassian, which we use for Confluence and Jira, and you're probably quite familiar with lots of those. So we've done a review of that, and we've now starting to migrate to the new offering from Atlassian, and we've already moved our Jira service over, and we will work on Confluence a little bit later after the conference. Obviously not the thing to do before the business meeting, so we'll leave that till afterwards. The other piece of work we're doing is around the browser API, and we are working to improve performance and trying to control the traffic that is on the browser. You might notice the browser is currently unavailable because that's exactly what's happened this morning, and we're busy trying to work to resolve that at the moment. I now wish that the browser API was in place now because I think it would be helping. Configuration management, so trying to control what all our servers are doing, how they're all set up, even basic things like how much memory it has and all of that sort of stuff. We've been implementing some new technologies to control all of that, make it more automated, and make it easier to make changes on the fly without disrupting the service. And so we've been working on doing that, and we'll continue rolling that out across our services. You shouldn't notice anything as from an end service perspective. It's all sort of just been done quietly in the background, as most of the stuff in operations does. Infrastructure projects, we've got to go around that whole merry-go-round we have to do every couple of years on updating our server operating systems, and so we're busy doing that and planning that project for this year. And we're now looking at Elasticsearch, which is where the main database for the authoring platform that we use is situated. It's also the back-end database for the browser. And we're looking at moving that to another host, and again, all looking at performance enhancements, making things quicker and easier to manage. Another big piece of work that's going on at the moment, which the team's been working really hard on recently, is security review. We're going through, we're checking all our systems, we're locking them down, we're making sure we've got the latest patches and all of that grand stuff. Very important piece of work, and that's an ongoing, it never ends. We're just doing a major focus on certain areas at the moment for that. We've also just signed up to a new service which allows sort of continuous sort of penetration testing of our tooling. We used to do this every year, but now this will be a continuous thing that happens all the way through. The downside of that is now the development team just get loads of tickets of things that the operations team keep finding that they need to fix. Moving on to the managed service. So we're currently at 13 members, which was the same as we had in Lisbon. We paused the onboarding of new members at that point. So no new members have been onboarded since then, but we are building up a steady queue. Frequent releases. So as Rory mentioned in his slides, one of the things we're trying to do is improve the frequent release work by allowing managed service users to trigger their own upgrades to the latest international. So when they want to do it, they'll be able to press a button, some great magic happens, and they get the latest version of international upgraded into the extension. So that's ready for user rollout, and that will be launched at the Managed Service User Group, and we'll be talking about that for the next couple of days. We've been working on some process workshops with Sweden and Norway, and we've had a couple of workshops in Oslo. And again, this is now ready for feedback, and it's about the processes that the NRCs need to be aware of to make frequent releases happen. Unfortunately, it's not all magic technology. There is some hard work involved, and the NRCs have got to do quite a big percentage of that work, as our international team know very well, in order to make this thing actually happen. And lastly, some tooling updates, specifically designed for the managed service, was the upgrade work, which I've mentioned. We also implemented a new service, which the international team have been using, which allows the much quicker and more faster way of reporting issues with their content. We've been doing some performance analysis to try and see how we can speed the platform up. And we've identified some things. We've applied that to the Norwegian extension, and the feedback we got was great, and it's definitely helped. So we'll now start rolling that out against the other ones. And as I said, we're continually looking to make things better, faster, and more stable. And the last thing we did was context-specific language reference sets, where you can actually set acceptability for a specific context, which could be labs, it could be nursing, it could be all these sorts of things. Sweden have a number of these, and what was happening in our user interface, it was becoming a bit squashed and a bit cramped. And we've now produced a new user interface for that, which makes it a lot easier. And the feedback we've had so far has been very positive. So that's been a good piece of work. If you're specifically interested on seeing any of the demos, not only of the managed service stuff, but also the other tooling improvements and changes we've made, Sonia, our development manager, will be doing a demo on Tuesday. And we're also doing stuff on Monday as well. So it's open to observers. So if anyone wants to pop in and hear and see what the managed service is up to, please feel free this afternoon, and tomorrow morning we'll be running the managed service user group. Thank you very much.
So with Terrence's presentation, that wraps up our community updates session for this morning. I do want to extend a big thanks to all members of the SNOMED International team for participating in this. I think it's really a useful exercise to get you thinking about the achievements, the developments that the organization has made with the strong support of members, core stakeholders, et cetera. We really value all of the input from each of you and value your time. So we really thank you for your participation and your attendance at these meetings. A couple of small housekeeping items so that you're kept aware and up to date. This evening, we will have a networking reception. It's in the 1901 ballroom, which is downstairs. That will also be the place where lunch will be served today. So please join us from 6 till 8. My apologies to the online participants. The Open General Assembly will take place tomorrow in this room at 1:30 p.m. BST. It will be broadcast as well and available via webinar online. So I do encourage our more than 50 participants that we have online at the moment to come back in and get updates on the statutory matters of the organization, as well as hearing some member updates as well. And lastly, on Wednesday afternoon, 4:30, we'll have a closing plenary session where we'll hear some report backs from the different advisory groups, working groups, project groups, clinical reference groups of the organization. It wouldn't be my chance to remind you of things if I didn't say that the Atlanta SNOMED CT Expo is this October. We are engaged in the call for abstracts process at the moment, looking to have your abstracts in by just the beginning of May, if possible. If that seems to be an untenable task, please reach out to me and my team, and we'll see what we can do to ensure that you get your projects into consideration for the Expo. So with that, I would really like to say enjoy the meetings that you have over the next couple of days. You can find all of them listed on the schedules outside of this room and online on Confluence. Many of them are open to participants and observers, so please go and connect with the individuals who provided you with so many updates this morning to learn more. Thank you very much, and I hope you have a great day.